Okay, welcome everybody to Ortho Talk. So, what I thought we would start this talk off with is kind of a basic explanation as to why I created Ortho Talk. So, the first reason I created Ortho Talk was to bridge gaps between clinicians, not only between ATs and PTs, but also PTs, ATs, and ortho docs. It'd be great if we could get a PM&R doc on here, but I think if we all kind of better understand where we come from knowledge-wise, we can better function as a healthcare team versus kind of as our own single entities. The second reason was to share ideas. I think a lot of us are kind of alone functioning with within our own athletic training rooms, with the example of Josh or Keelan and I with our own PT clinics, and we can share ideas amongst those within our clinic, but we kind of miss out on all those other ideas that people are creating in other clinics in the surrounding areas and even nationally. So what better way to connect than using technology? All right, so without further ado, let's go ahead and introduce ourselves. Keelan, we'll start with you.
All right, Keelan Secchi, physical therapist and athletic trainer. I'm in practice at the University of Pittsburgh Center for Sports Medicine, Centers for Rehab Services. Also, I'm an adjunct faculty at the University of Pittsburgh, and I'm the director of the UPMC Orthopedic Physical Therapy Residency.
All right, awesome. Josh?
Josh Edwards. I just graduated from Western Carolina University in athletic training and taking the summer off, and I'll be starting the Doctor of Physical Therapy program at Western Carolina as well this coming fall. So,
Okay, great, and definitely, Keelan, we're definitely glad to have you on here. Keelan's one of our local experts as well as a national expert and has done a lot of things within the APTA organization and definitely is a big name within the profession, so we're definitely glad to have you. So the talk that we're going to have tonight is on sports hernia or athletic pubalgia. You might have seen either name in the literature. And I'm definitely glad we're kind of discussing this because it's definitely a complex disorder, and definitely within my limited experience, a lot of these athletes or patients will go through lengthy rehabs without kind of their symptoms or their pain resolving, and often end up getting surgery. And one of the most resounding things I think I found in the literature thus far within my research is that they were simply stating that conservative approaches just don't work. So I think we have a lot of work to do as therapists and athletic trainers to better understand this topic and how to treat it. So I thought the first question I wanted to ask you guys to start off with is, how are you defining sports hernia? You know, you get that script from the doc, and it says sports hernia, eval and treat. How are you defining it in your practice, I guess?
There we go.
Yeah, anyone can go.
In my case, sometimes I'll get the sports hernia athletic pubalgia diagnosis. Sometimes I'll just get a chronic inguinal or groin pain diagnosis. I still occasionally do see people in direct access. And for everything we have available right now, it's still a diagnosis of exclusion. I think we're getting better at it, but we're still ruling out some of the things that are more common, anything from intra-articular issues of the hip, of course, labral tears and impingement being an issue, and we think there's an association between the two, that sometimes a true hernia, a classic hernia, if you will, abdominal strains, psoas strains, and other issues, even bursitis, psoas, bacterial bursitis. So, and my definition is still it's chronic inguinal pain that we can't explain without any other, with any other pathology being the primary cause. And also, we still have to define it as something that's related to exertion. Thus, the name athletic pubalgia, where many times I think we're tagging this diagnosis to too many other issues, though we can't define them. It's not truly athletic pubalgia.
Gotcha. Josh, anything that you guys are doing differently in the athletic training room when an athlete comes to you?
I guess normally with us, we're not really getting the script, so it's kind of going along with the evaluation and everything. And just like he said, the exactly is the diagnosis of exclusion, and basically, it's only happening when they're doing exertion and ruling out all the other things. So I'd have to agree with everything he said.
Okay, great, and we'll definitely get back to how we're defining it in our examination, but kind of how I've seen it defined most often within the literature is a tear of the posterior inguinal wall without a clinically recognizable hernia. And I think it's easy, to determine the pathology, if you're a surgeon and you go in there because, you can visually see it. But I think the problem becomes confounded clinically for us because a lot of these athletes are presenting, so differently. Some might have just pain over the pubic tubercle along with testicular pain. Others might just have, pain over the pubic tubercle and pain over the adductor longus. So I think it becomes a lot more difficult for us to define clinically. I guess the next question I have for you guys is, are the anatomical components important to us? Is it important to rule out an inguinal hernia versus like a testicular problem or a femoral neck stress fracture, that sort of thing? Is it important to define or clinically differentiate between, let's say, osteitis pubis and, I don't know, maybe just an adductor strain or something like that? Do you guys believe that's important to define clinically?
I think it's important to rule out all clinical things that would require, all other clinical entities that would require further treatment. So there's some important ones that you mentioned: a femoral neck stress fracture, even really an occult hernia. But there's some diagnoses where it probably would not matter. We could classify that we're going to treat a number of these people by their impairments. So whether it actually would be a lower abdominal strain, even osteitis pubis, some of your other issues that we would probably use the same examination scenario. And even if we weren't able to identify the exact pathology, we'd probably treat these individuals the same way. But we do have to rule out things that can progressively become worse, or that they're not going to be amenable to rehab. So I think we have to at least exclude the red flags or things that are inappropriate to treat. After that, it may not. It's helpful, and we would love to obviously know all the time. But even the best diagnostic techniques for this particular issue aren't the greatest. Sometimes they don't even know until surgery what they're identifying. That includes MRI, and other imaging modalities.
Gotcha. Josh?
Yeah, I mean, I think it's definitely clinically important because if it's a runner or female, I mean, you have to address other things as well. So you have to go after it the diet way instead of looking at all the other pictures besides of just if it's the one thing. So I think it's definitely important.
Definitely, and I mean, I agree. I think it's first, most important to rule out some of those red flag conditions, such as a testicular torsion or an actual inguinal hernia. They've got the bulge there and that sort of thing. Kind of moving on here, getting into the examination. Keelan, you kind of talked about this earlier, but how are you defining it during your examination? Let's say you don't get that script and you get, that patient coming in with just groin pain. How are you differentiating, let's say a groin strain from, a sports hernia?
At this point, if you look at the literature, we don't have a great set of tests or cluster of tests like we do for other issues, and part of that is because the issue is kind of a dynamic issue in itself where it's not as well defined. So I think the importance is a structured approach. So what we'll do is I'll start with, and it's not much different than the way I treat anybody who comes in inguinal pain, whether I suspect this or not, an approach where we rule out adjacent issues, particularly the lumbosacral spine, which is pretty easy to do. I think with given a good history and then just a few screening tests, those are negative. Then we move on to intra-articular testing of the hip. Now, in truth, we know you can see some of these things in combination, and then that's a little more of a judgment call. But if I can rule out through a few of the screening tests that we use for intra-articular conditions of the hip, we now move to just whether the question, we think it's extra-articular, just what exactly it is. And at that point, some of my key elements of my exam, negative test for intra-articular involvement. I usually look for a combination of some provocative tests from both muscles across the hip joint and the lower abdomen. Makes me very suspicious. So very simple clinical exam, pain with adductor strength testing, pain with potentially hip flexion, and then I'll do a resisted leg lowering, resisted sit-up, where often with intra-articular issues of the hip, that's not impossible. We may not just have much pain with some of the abdominal testing. And of course, any palpatory exam, but we know that's not always the greatest either. So you combine that with your history and take a look at it as a cluster. The higher percentage of those tests that are positive, the greater clinical suspicion is for this.
Great. Josh, anything that you're doing differently?
I have nothing to add.
Okay. Great. And Keelan, I thought that was
great. That was great.
Yeah, a great explanation. And a lot of these, I kind of had my own little version here, but a lot of these I learned while working under you. A couple of things that I had down were painful on stretch of the adductors, painful over the pubic tubercle and symphysis, pain with a resisted abdominal contraction, and then pain, kind of disappearing with rest, but then returns, when they try to return to activity. So kind of that same cluster of symptoms that you just mentioned there. The next thing I kind of wanted to talk to you guys about is kind of the mechanism of injury. How do we believe this happens? Is there anything that we can do to intervene prevention-wise? Josh, I don't know if you guys are doing anything prevention-wise in the athletic training room for your athletes, or I guess let's start with general mechanism. How do you guys believe this problem develops? I know there's a lot of theories out there that I've kind of read, but I just wanted to kind of get you guys' thoughts on that.
Josh, go first here.
Okay. I guess based off of what I saw at a seminar recently, a surgeon kind of presented what are some really big things that he's encountered and stuff is a lot of abdominal weakness and stuff can cause, he thought could cause, predispose someone to athletic pubalgia. So I guess in theory we could strengthen the core to try and prevent it, but even then I'm not really too sure if that would do anything. But other than that, I mean, just watching, their mechanism, I'm not too sure.
Okay, and
if there's any preventative, really.
Okay, and in terms of the abdominal strengthening, were you talking about more of the superficial abdominal muscles or more of the deep abdominal muscles, like we're talking transverse abdominis, that sort of thing, versus, maybe like a rectus abdominis or something like that?
He was talking more rectus abdominis because with the cadaver testing that he's done, he always gets his new people who are following him to do this with him, and they'll put their finger kind of on the adductors, and he'll cut the rectus abdominis, and then their finger will get pinched. I guess that kind of displays how if the abdominals are weak, it kind of puts more pressure on the adductors.
Okay.
Yeah.
Gotcha. I know one of the things that I read was that basically there's a muscle imbalance between the rectus abdominis and the adductors. So, for example, the rectus abdominis is posteriorly rotating the pelvis versus those adductors, which are anteriorly rotating the pelvis. And so you've got this kind of this pull and strain in opposite directions, which all kind of centers around, the pubic bone there, and creates a lot of that stress.
Okay.
Yeah. And Keelan, I don't know if you have anything to add there, but
yeah, and you're both right. I think as far as from what we know, it's an imbalance issue is what the thought is, and really I think it comes down to the complexity of what we, particularly in athletic, in daily life, but then when you get to athletic endeavors, it's even a higher level. What we use to stabilize the pelvis, and there's over 20-something muscles that stabilize that area, and then when we, as athletes. Athletes, use repetitive movements, forceful movements. They tend to become stronger in some areas than others, and lower abdominal weakness definitely being one of those issues where we just have, overpowering of one muscle group over the other, and then the secondary, even micro trauma that builds up to some threshold where it becomes symptomatic, and we lose dynamic control of the pubic, the whole pubic complex, and that complex, though it moves, should be fairly stable. When we start to lose stability, and the usual thought right now is that it creates this excessive anterior tilt of the pelvis, and then you start to see these secondary issues with small rectus tears, aponeurosis tears, pubic symphysitis along with this. Then I think it's when you get into that spectrum of athletic pubalgia. And right now, there's nothing out there that really defines a really good preventative program for it. I think the best we can do is recognize what the issues seem to be, and that is that imbalance. And like just mentioned, strengthening the lower abdominal musculature. Maybe in the future, what we may see, though harder to define, is it may be activity and practice modification for those populations that we know are at risk for this type of injury.
Yeah, and I know Keelan, I know you mentioned earlier kind of its the significance in relation to the hip to this disorder, and I was kind of watching a talk earlier, and they were saying, you were kind of talking about the imbalance between the lower abdominal muscles and the adductors kind of creating this anterior pelvic tilt. So I guess she was explaining the fact that when you get that excessive anterior tilt of the pelvis, you kind of get impingement of like that anterior portion of the labrum, which we know is the softest portion of the labrum, which can kind of create undue stress in that area and tears within the labrum. So that I was thinking maybe that could be a possible relation there.
No, they're definitely looking at that now, and now they're looking at that. Well, we already know as separate populations there are these people who develop athletic pubalgia, and there's definitely certain, hockey's a big one for this, but there's other martial arts and other sports, soccer. They're at risk for the athletic pubalgia. They're also at risk for these labral tears due to impingement. Impingement is already an issue, so if they have a structural predisposition, you add in loss of pelvic control, you're already at risk, and you have excessive anterior tilt, you're probably going to expedite the issues that come along with impingement. So there's one article in the literature, and I can't remember, I think it's Brian Kelly and Craig Marley, these individuals who see a lot of hip patients describe, I think they call it the unhappy hip triad or something of that nature, where you have athletic pubalgia, adductor longus tendonitis, and impingement. So there's an association, a subpopulation of patients that have these issues. Which came first, we don't always know. I mean, if there's a bony abnormality, I guess you can say that's a predisposition, but it's probably a combination of anatomy, activity, and some other factors we haven't identified yet. And I think that's probably the next line of research or development with some of these protocols, is looking at these numerous factors, that end up resulting in these issues.
Right. And I know the hardest thing for me clinically has been is I guess establishing where the dysfunction is. So do we have this abnormal contraction of the abdominals or the adductors, and how are we determining which one is overactive or underactive? And I don't know if you guys have read anywhere in the literature of a really good way to test the abdominal muscles or the adductor muscles. Like, are you guys using dynamometry? How are we getting a quantitative measurement to see which muscle is underactive, which muscle is overactive, to kind of create more of a treatment plan for these athletes or patients? And I'm not sure that there's an answer to that necessarily, but something.
I don't think there's anything out there. I mean, in comparison to where we do have actually data on, for example, I think I was not going to say it's more simple, but when we look at quad versus hamstring ratios, we can define that. We can put people on machines to get objective numbers. We could probably get objective numbers for dynamometry for hip muscles, for lower abdominal muscles. Very hard to do, particularly as we're moving in several planes of motion, and every sport is different, and we don't have any defined ratios for that as well. So it's very difficult to do. I mean, for me right now, I'd be honest, I just think it's no more than clinical judgment. Of course, I'm also seeing these people when they're already symptomatic, and that makes it even more challenging. But
absolutely,
as of right now, we only have a qualitative way of kind of describing what we think is happening. I don't think there's any literature out there that puts numbers on this type of injury, not at this point.
Yeah, for sure. I mean, I was thinking, with the adductors, possibly we could use dynamometry and start to get some normative values for that. But yeah, you're right. I mean, as far as like the core musculature goes, and even the deeper core muscles, I mean, it would be very hard to kind of test that. I mean, other than on palpation and to tell whether or not, okay, is the muscle contracting or not. But yeah, definitely good discussion there. All right, so the next question is for you guys is, are you evaluating movement? You've got that patient that comes in that's an athlete. Are you looking at how they move and trying to relate that to the injury, and then therefore creating a treatment plan? Or if it's a general patient, are you watching to see how they do? If they're manual labor, are you seeing how they're performing their activities at work? Anything like that? I mean, do you guys find that of value, or?
Yeah, I would find that of huge value, especially if it's like a kicker or soccer player. You can also watch them and record them and see if they're weak in some areas or they're not stabilizing in others, and just looking at their movement patterns. Definitely, yeah, I think that's definitely very valuable.
Yeah, I mean, I think quality of movement is always, and there's many different schools of thought, but I mean, I think even if you don't agree on one or the other, some attention to quality of movement is very helpful, just like it is with any other diagnosis. Maybe more important because there are so many different factors here, and that's one thing we identify is what isn't proper quality of movement. Now, sometimes that's you have to. You may have to work together with or consult with, when the special, for example, golf, someone's golf game. I would have to consult with someone who specializes in teaching that to know what is right or what is wrong, and identify those things that should be different and those things that are just inherent to the activity. But yeah, I mean, anything that is that you can identify and potentially change that doesn't obviously destroy their technique or it greatly undermine their performance. I mean, those things should be paid attention to for preventative measures, particularly. I would think.
Absolutely, and I agree. And I know Eric, if he was here, he was going to bring up this case, but he actually had a guy that came in that I believe he was out working on his tractor, or his tractor or something like that, manual labor type patient, and started pretty much to develop all of these symptoms that were right in line with what we were talking about earlier in terms of a sports hernia. And he went to go see a doc, and the doc said, "Well, you're not an athlete, so you can't have a sports hernia." Which, in my opinion, that's totally wrong. Even though they might be, or they're not an athlete, they're still experiencing a lot of those same repetitive forces, at the hip and the pelvis and the lower abdominal region that I think an athlete would, especially, even more so on a repetitive basis. It might not be as high speed, but, depending on the job, it could be.
Your body's only going to recognize forces, not whether it's a sport or not. So,
Yeah.
Just mechanical issues more than anything else.
Exactly. No, I agree. Next in line here is kind of treatment. And we've already kind of talked about this a little bit, but how are you guys? Do you have a specific protocol that you like to follow, Keelan? I know you sent me a Word document. Josh, are they sending you something to treat athletes with in the athletic training room? Or is it more just patient dependent? What are some things that you're really focusing on?
Oh, Josh is good.
Okay.
Yeah.
Go ahead.
I don't think anywhere I've had my clinicals we haven't had any specific protocol. I haven't really seen any protocol, but I'm sure there are a lot of protocols out there that could be very effective. Since I'm not practicing, I haven't made my own protocol, but I'm sure that it's probably a lot more focused on not doing the movement that's caused it and trying to work out the muscle imbalances. But other than that, I'm not too sure.
There's not any real there's post-surgical protocols which are published or at least fairly well known, and those vary greatly. But for conservative treatment, the only thing, there's very little out there. You'll see a few case studies. There was one in the Journal of Orthopedic Sports Physical Therapy. They actually, they did a good job describing the protocol and how they treated. It was a case series of individuals with suspected sports hernia, and they listed everything from mobilization of the SI joint to strengthening and stretching exercises. So, my question to that sometimes is I don't know if all these people really had a sports hernia or not. Right. So the diagnosis, if you don't have that right, then, and I'm not saying they didn't, but that may be there may be some issues with that. But to be honest, a lot of it is impairment based, and for me, it's kind of changing depending on the severity and who I'm treating. There always has to be a rest phase, regardless. They have to, at least in the short term, modify their activity. Mm-hmm. There's some, there's not much out there in some conjunct treatments, such as, sometimes combining this with an anti-inflammatory in the short term if it's prescribed, or injections have been used at times. Sometimes they're more diagnostic than anything else. But then after the rest phase, you do have to, particularly, usually if I can find specific impairments of these people, we'll address those, whether it be lower abdominal weakness. Stretching is always a big issue if we find tightness. The most difficult individuals to treat are those who come in and on exam have almost no findings that are abnormal. They look good from what you can tell with strength, range of motion, flexibility. You hope you can find something maybe in their movement patterns. If you can't find that, then those are the tough people to treat, and we don't have a really great answer for those individuals. And rest is one thing, but a certain percentage of individuals with rest just go right back, and within a short period of time they're symptomatic again when they start training.
Yeah, no, I agree. Some things that I try to focus on. Again, I try to see if they're at least contracting, the transverse abdominis. I don't spend a whole lot of time on that. I don't really get in there, and if they're not getting it, I don't try to just continually, hop on the fact that they're not getting it. But I at least try to see if it's inhibited and see if we can't at least get some of the core abdominal musculature strengthening, before movement and before activity and that sort of thing. I try to look at the muscle imbalance as best I can. I try to see, by palpation, if the adductors are overactive. I try some soft tissue work, and then I'll try to, obviously do some lower abdominal strengthening for the core. But, other than that, I just try to look at their movement to see if there's a way in which I could change their movement pattern that I feel puts less stress through that pubic area. So, all right. So the last question I had for you guys here, was consistency in naming the syndrome. What do you guys think about, the term sports hernia? To me, it's kind of a misnomer. It's not actually a hernia. Should we be calling it athletic pubalgia? What are you guys, telling your patients? And then I don't know. What do you guys think we should move to a more central name in the literature? Is that even possible? But
there are 20 different names for it too. That's a problem. Sports hernia is just the one. It's in the popular. It's you hear it all over. It's not hernia really. But
yeah.
I don't know if you're ever going to really outlive that name. Athletic pubalgia is better. Probably better called exertional pubalgia.
Right.
Because it's really what we're looking at, pain with exertion. That's chronic inguinal groin pain, lower abdominal pain with exertion. But you'll hear Gilmore's groin, and I can't even remember the other hockey player's groin. You'll hear a million different things, and that's the problem with it. We can't define what it is, and then we can't even name it when we do think we have it defined.
Yeah.
Right. No, I totally agree. I mean, Keelan, I don't know if I got so confused when I was kind of in the literature, but is there a difference between a sports hernia and versus like a Gilmore's groin and then a hockey player syndrome, and are they all kind of the same? I know there's probably a lot of confusion out there.
I think there's no agreement on that. Because some of those, like hockey players' groins, often thought of as chronic adductor longus strain, which can be part of the spectrum of athletic pubalgia, but alone typically isn't considered that. So I think Gilmore's groin, or I think it's the hockey player's groin, one of the two is adductor longus tendonitis. It's chronic, or just adductor longus tendonitis. It's often considered part of the spectrum, but in isolation, not really considered athletic pubalgia. But with that force couple being off, sometimes it is part of that spectrum, and that's what's confusing about it. And it probably that affects treatment too, because it's only one isolated issue like adductor longus tendinosis. That could probably be treated a little differently. They may respond better to injection in a very focused program of numerous interventions, where they may not respond as well if that's only one part of the one piece of the puzzle.
Right. Agreed. Josh, anything to add?
No, I just feel like the athletic pubalgia is just such a bucket pail term. They're throwing 20 different diagnoses. If it's the aponeurosis, if it's all the different muscles, they're just throwing it in there. So I think when we start to get a better diagnostic accuracy and value, where we actually figured out what's going on, we're not going to be able to name it.
Yep. Gotcha. All right, guys. Well, definitely appreciate you coming out and talking about this. We'll come up with another topic for next week. Keelan, awesome job. Thanks for coming on. We really appreciate you having you. And we'll catch you next week.
All right, thank you.
All right, take care.
See ya. Have a happy 4th.
All right, you too.
All right, bye.